So as Sir mentioned, today we'll be talking about case of an incisional hernia. So talking about my patient, Mr. A, he's a 68-year gentleman. He is Asian Indian, resident of Shahadra, Delhi. Is a retired factory worker. His work involved lifting heavy machines and is literate. He presented with the chief complaints of swelling over the central and lower abdomen for 20 years and constipation for 2 years. So my patient was apparently all right 20 years back when he underwent emergency midline exploratory laparotomy and loop ileostomy creation for query perforation peritonitis. He then underwent stoma reversal 11 weeks later via the same midline incision. Then he developed wound dehiscence post-operatively and underwent debridement of wound and closure 4 weeks later. After this, he started developing swelling over the central and lower abdomen over the scar for 20 years. It was insidious in onset, gradually progressive, increases in size on cuffing and straining, and decreases on lying down initially, but now it reduces partially for 2 years on lying down. There is associated dull aching pain over the swelling and lower back pain for past 2 years. It is aggravated on straining and it decreases on lying down and over-the-counter analgesics. He also has complaints of constipation on and off for the past 2 years. However, he passes normal colored stools of firm consistency once in 2 to 3 days. He doesn't have a history of fever that was associated with the abdominal pain, any vomiting or non-passage of flatus, ulcer or discharge of or blackening of the skin over the swelling, or any respiratory or urinary complaints. He is a hypertensive on medications. Past history, he underwent emergency midline exploratory laparotomy and loop ileostomy creation for perforation peritonitis, and after 11 weeks stoma reversal was done. There was wound dehiscence, and that is why he underwent debridement and wound closure 4 weeks later. There is no history of any respiratory or urinary disease and no drug allergy. Talking about the personal history, he is a chronic smoker, smoking cigarettes for 45 years, 4 per day, which is 9 pack years. He doesn't have history of any other substance abuse. He has been on some Ayurvedic medication for 6 months for constipation. His sleep, appetite, and urinary bladder habits are normal. He consumes mixed diet and he is on medication for hypertension. There is no history of abdominal swellings in the family, no known history of malignancies, tuberculosis, diabetes mellitus, or respiratory illness in the family. Summarizing my case, a 68-year Asian gentleman who is a known hypertensive and chronic smoker. He presented with a swelling over the central and lower abdomen for the past 20 years, which was insidious in onset, gradually progressive, increases in size on cuffing and straining, and decreases on lying down, but now it reduces partially for 2 years on lying down, with an associated dull aching pain over the swelling and lower back pain for the past 2 years and constipation for 2 years. He underwent emergency midline exploratory laparotomy and loop ileostomy for perforation peritonitis 20 years back, and then stoma reversal 11 weeks later via the same midline incision, after which he developed wound dehiscence postoperatively and underwent debridement of wound and closure 4 weeks later.
So I think we'll take a little break here and we'll discuss a few points.
Yes, sir.
You see, the point is that from where to start your history of present illness. Your history of present illness in this patient starts from the point when he started developing swelling in the scar following that surgery that he underwent, right?
Yes,
so
sir.
I think the previous surgery or the surgery that led to this problem should be in the past history, right? So you should mention that patient has been having a swelling at the incision site for the last 20 years. So that's how the history of present illness should start. And the past illness is that he underwent a surgery, he underwent an operation for an intestinal problem. And these were 2 surgeries, complicated, and he developed wound dehiscence. And then subsequently, the swelling that occurred in that area led to, has been increasing and has led to his coming over for the current treatment or current management of his problem. So that's how, the history of present illness, there is a definitive point from where you have to start it.
Okay.
Okay.
Yes, sir.
Okay. So, and it has been progressive. It has been increasing in size. So
Yes,
you
sir.
have given quite a bit of importance to constipation. Can you tell us why you give so much importance to constipation in this patient?
Sir, this was one of his chief complaints. First thing. Second thing is when there is incisional hernia, which probably leads to loss of domain of the abdomen, then the power of the muscles to contract and create an intra-abdominal pressure for straining reduces. That is why patient develops constipation as well as low back pain.
Yes, I think you're very right. And I think this is what one needs to understand, that when a patient has an incisional hernia and it's a large incisional hernia, his abdominal muscles become ineffective in creating enough intraperitoneal, intra-abdominal pressure to evacuate the bowel. So I think that's the paradigm that one has to understand, that intact musculature is important for creating a proper intra-abdominal pressure to expel the feces. Okay, so it's not that constipation has resulted in this hernia, or it is that the constipation is a result of a hernia, and the hernia has rendered the uh, abdominal musculature ineffective in creating enough or adequate intra-abdominal pressure. So that's the point that you should keep in mind.
Yes.
Okay. So what are the other points in the history and the points that we have discussed so far we need to take cognizance of?
So first thing that the cause of this hernia, which was an emergency surgery,
That's
and
fine.
because then
You
he's
see, as patient is concerned, we all know that when the patient undergoes any abdominal operation, there is a chance that the patient may develop a hernia. The chances are more if the patient has undergone emergency surgery, and chances are more if the patient develops a wound infection. Right. So these are the risk factors for the patient developing an incisional hernia. Emergency laparotomy in this patient, and the wound getting infected and patient developing dehiscence. So these are the things, which has led to this problem in this patient. What more we need to know about this patient? Because now we have to look forward and see, what we would need to do for him to set right his problem.
So second thing is that he was a chronic smoker. So because of smoking also there is ineffective collagen formation and that can also lead to incisional hernia. And he's old age patient. Already his musculature is weak. So that could be one of the other reasons as well.
You see, one has to look at the smoking in a very holistic manner. And they say that once a patient has a history of smoking, this patient has a high risk of developing post-operative complication. His wound healing is poor, right? So these are very important things. And if you want that these factors are mitigated, then the patient has to stop smoking at least a month before surgery. It is not like this that you can call the patient to the operating room and start operating on these patients. If you want smoking to be taken away from the equation of wound complications and other complications, then the patient has to stop smoking. uh,
Yes, sir.
Sorry,
1 month.
start 1 month before, right? And smoking, as you have very rightly said, results in poor quality collagen, collagen 1 and collagen 3. Collagen 1 is the stronger form of collagen, and collagen 3 is the weaker form of the
Weaker.
collagen. This collagen 3 is more preponderant in patients who are smoking and doesn't get cross-linked to become collagen 1. So these are all things that you should remember. And why it is important? Because when you would be operating this patient, you have to ensure that the patient is not smoking for at least 1 month. Then only you can reduce the complications related to smoking. And another important related point is that these patients may be also having COPD, and COPD.